each day there's like during the NICU Awareness Month, there's always one about full-term NICU babies and how, it's not just preemies, they call it the Not Just Preemies campaign. On any given time in the NICU, what would you say like a typical ratio is to preemie babies to full-term babies? It probably changes a lot. I was just curious how well represented full-term babies are.
Our tiny baby unit is 12 beds.
Okay.
So they're in completely different space of the hospital than we are.
Okay.
And then we have our step down tiny baby, which is another 12 beds. So after they get booted out of 12 tiny baby, they get booted to the regular unit, which is step down tiny baby. But because the way we match acuity to nurses, so the normal ratio in the NICU is 2 babies to 1 nurse. Sometimes 3 babies to 1 nurse, and sometimes 1 baby to 1 nurse. So like all of your cooling babies are 1-to-1s, right? All of your kids that are super sick on pressors are generally 1-to-1s. Your ECMO babies are 2 nurses to 1 patient, because you have someone running the ECMO circuit and then you have someone taking care of the patient. And then our 3-to-1s are like our grower feeders, our stable babies. And those could be the tiny babies, preemies, that just have feeding issues, but they're not having any breathing issues. They don't have any lines. They may have some IV medication, but typically we try to keep them the easiest, because you got 3 babies to 1 nurse, right? So those are your super easy, chill patients. Those are the babies. What gets those nurses busy is the discharge process, okay? And then the rest of them are like a mix. So you might have like just a vented kid who's post-surgical, but who's stable, paired with a hyperbilly, right? Or a choreo baby gets paired with a baby that's that's chronic because they're a cardiac baby, they're waiting for transplant, or they're waiting for a cardiac procedure. So we have to balance how we pair those babies so that those nurses aren't drowning the whole time, versus also a nurse that's just sitting there doing nothing all day. So it's really hard to answer that question because they're all in different stages. We do try to get them out as fast as we can, but then we have some kids that just can't go anywhere. Like there's no room in PICU, or they're not stable enough to move up to PICU after they get up to a certain age. So it completely varies. We've had kids as old as 8 or 9 months still in the NICU. We don't like to keep them that long. I mean, there's some NICUs that will keep kids up until 2 years of age in the NICU, but we're not one of those. We want to get them home, out to acute care facility, or upstairs to acute care peds or PICU.
With the kids who are preemies, because at first I'm picturing a 9-month-old, and there's probably 9-month-old sick babies in there that were maybe full term but have a cardiac event or something, or waiting on that. But I'm guessing a lot of those are probably preemies that just are trying to catch up to their what their gestational age, or what they should, I always forget what you call it.
Right. So, when you're born at 24, 25, 23
adjusted, right?
Well, let's say you're born at 25 weeks and you're a pound, 500 grams. Okay. You have a long journey just to get to 40 weeks gestation, right? Right. And in that time, we are growing all parts of that baby. We're growing the gut, we're growing the brain, we're growing the eyes, we're growing the lungs. The major complications from having a micropreemie, a baby born between 23 and 28 weeks, 30 weeks, which is our tiny baby unit, is lung problems and gut problems and brain problems, okay? So let's say you have a 25-weeker and then 2 weeks in, you get a bilateral bleed in the brain. So now you're a neuro kid, right? And we're going to start watching that and how severe that brain bleed gets. Let's say it keeps going bigger and bigger and bigger. And we've told the parents that this could be catastrophic, but they want to keep going. So then by the time the baby hits 30 weeks, we might need to put in a shunt when the baby gets big enough. So then that baby stays in the NICU because it has a brain injury, but that baby may also have a lung injury because it's been intubated the whole time because it has a brain injury. So it doesn't learn how to breathe properly. So it's been on a ventilator the entire time, and the ventilator causes lung damage. So then that baby can't wean off the vent, and then they get trached. And then let's say it took a hit to the gut as well. And so that baby can't feed. And then we finally get it big enough to where the gut is healthy enough to feed, but the baby can't suck, swallow, breathe because of the lung issue. So we got to put in a G tube. So some of these kids that start off as a 25-weeker end up in the NICU until they're, let's say they're 60 weeks, right? So they'd be 20 weeks past their due date, but they're not a normal 10-month-old because they have all these additional things going on. And so they end up being in the NICU a lot longer. Does that make sense?
That makes sense. If a baby is born a preemie, but maybe not a micro preemie, like a 32-weeker or 33-weeker, and they end up doing pretty well other than just being small and needing a couple of things, do you guys still typically keep them closer to like where they would have hit 40 weeks, or if they're healthy, do you discharge them sooner?
As long as they can legally go home in a car seat, we will discharge them home. So if you have a baby that's born at 33 weeks and is amazing and is eating everything and growing, gaining weight, hitting everything it's supposed to, but hasn't hit 4 pounds yet, they ain't going home. But once they hit 4 pounds and they can pass their car seat test, they can go home before their due date.
What kind of things does all the babies have to go through in order for them to be like checked off of, okay, now you can go home?
The number one thing we tell the parents is they need to be able to eat on their own and to gain weight. Because even if they can eat on their own and they're not gaining weight, they're burning more calories than they're taking in, we're not going to send them home, right? So what causes them to burn calories? Temperature instability. So we want to make sure that their temperature is stable. What causes them to burn more calories is breathing. If their breathing isn't right, they're going to stay there. So that's why we always say feeding and growing weight at a regular way without any events. So a lot of babies, when they're first born, they forget how to suck, swallow, breathe, and they'll do what we call a Brady DSAT. So if they're having multiple Brady DSATs, they're not going to go home. Okay. So, and then a lot of these kids too, they develop a lot of reflux because we have asked them to do things that they weren't designed to do yet. Right. And that's to eat food and to keep it down. So then they get reflux, and a lot of them will Brady DSAT with the reflux, or they won't gain weight. So what we tell parents look for is eating 100% and gaining weight, because those are the last two things that we're looking for before we send them home.
Is there any other checks other than the car seat one? We know the car seat one is a big deal for all babies going home. Is there anything else, or just that one?
Well, that's the end game, right? But I mean, we're looking at all these things to begin with. Like, let's say you had a kid that had come in and they had some lung damage, and they're doing everything, but they're still having a problem with the respiratory. We might send them home on oxygen, right? So we'll get that set up, and they'll go home on oxygen and a monitor to make sure that they're not desatting while they're on the oxygen. So there are different stages. Let's say you have a full-term kid born to a mom with gestational diabetes, and this kid just doesn't want to feed. That's a huge problem with diabetic babies. They don't have the stamina to feed. And so let's say this baby's 43, 44 weeks gestational age now and just not feeding well, we're going to counsel that mom about a G tube so that we can just get that baby home. And then she can continue to work on feedings at home, physical therapy, outpatient, occupational therapy, outpatient, to get that baby feeding. Because a G tube doesn't mean it's for life. It's just means to get your baby home. So we'll talk to them about that too. But I mean, we're not going to do it right at 40 weeks. We're going to give that baby some time, give it a chance, work with it. And then if we're still having a problem, we might counsel them about getting a G tube. And then usually once they get the G tube, they're home within a week to 10 days. So, if it means staying in a hospital another month or going home in a week, we're going to talk to them about that. So there's multiple check marks. It's not just one thing. This the big picture that we're looking at.